In sub-Saharan Africa, 250,000 children are born every year with sickle cell disease. Most will never be diagnosed, most will never receive care, and 70% will not survive past the age of 5. But in Ndiwa, Western Kenya, something changed. Led by the SHIKURI Project and supported by your donations, the first ever sickle cell clinic was launched in Ndiwa sub-county. In partnership with local hospitals, we screened 200 patients and 44 children were diagnosed. 25 children under 5 who would have been forgotten are now receiving life-saving treatment. Each child receives 3 months of essential medication, blood tests and clinical care, digital thermometers, counseling and a custom care plan. We trained 15 local health promoters to follow up with families because our fight doesn't end at the clinic. And on June 6, 2025, the SHIKURI Project held its second quarterly clinic. In partnership with Homa Bay Hospital and county health practitioners, we continue to provide clinical care, essential medications, and ongoing monitoring, giving these children a fighting chance and their families hope. Meet Vidya, just 9 months old. Her father left when he heard her diagnosis. Now her mother, just 19, fights alone with our help. Meet Greg, Eric, and Denver. Each born into pain, stigma, and silence. Each now receiving hope, care, and a second chance. This is just the beginning. To turn this moment into a movement, we aim to establish ongoing clinics across Western Kenya. You can help us reach more families. Support our work. Donate today, because no child should suffer in silence.
Welcome to My Harlem Portraits, the show that aims at shedding the light on the fundamental contribution of African Americans to the building of this country and on Black excellence. We're going to talk about the SHIKURI Project. The SHIKURI Project is a nonprofit organization which is dedicated to improving survival and quality of life for children living with sickle cell anemia in undeserved community in Kenya, specifically Homa Bay County, which has the highest infant mortality rate. And we are going to talk about it with the one who created this, the founder, Miss Gail Sealy, who is my friend. She's been my friend for many years. And I know how much she has dedicated to this project. So welcome, Gail, to My Harlem Portraits.
Maria, thank you so much for having me. It's wonderful. Thank you for inviting me to talk about this program. Yes. Yeah.
So tell me, first of all, let's talk about where you come from, your career. We met at the UN conference because you have been working in the UN all your career. Tell us a little bit about that.
Okay, so I'm Jamaican born, and I was fortunate to have a wonderful career with the United Nations. I did project management for development in my first few years of my career. I worked in Nigeria on international development, where we worked on monitoring and getting finance for programs for global growth, economic growth, and sustainability of countries. So this is my heart. Global development is my mission, and I was fortunate to work in it. Later on, because of an illness, I ended up doing human resources management, where I happened to also get the chance to live in Kenya and had the Asia region also. It was during the time that I was in Kenya that I met my son. I'm going into more information now. Would you like me to continue that?
Yes, we'll talk about that in a moment because...
Okay, yes. So I had a 35-year career in the UN. And so I was not intimidated by starting something that required reach beyond my shores. I understood how to, work with individuals in other countries, how to establish networks, or at least that it was doable.
Thank you for that, Gail. And now tell me, how did you meet SHIKURI, who's your son, and what convinced you to take on this challenge?
I met my son in Kenya during one of my missions where I was thinking of adoption. I couldn't have my own children. And so I decided, let me try and adopt a child who is in need. And so I went to an orphanage in Kenya. It was love at first sight for us both. He was a year old.
Oh, wow.
He felt at home in my arms. And the deal was done. So I started working on the adoption from New York. I went back to New York, where my job was, arranged to go back to Kenya to work on the adoption. It was while I was working on the adoption. No, they told me initially that he was healthy, and he did look very healthy, bouncing, robust baby boy. When I went back to formalize the adoption, I was told that he had HIV. Then I had him tested at a proper hospital. And they told me he had sickle cell disease, which I knew nothing about.
Mm-hmm.
And they told me the prognosis was grim. He probably wouldn't survive. He would be sick all the time. It was not a viable proposition, but I thought, who better to help him than me? And so our journey together began.
Wonderful.
So that's my son. And I said, look, we're going to make this work. And with the help of God and the universe, things will work for us. And we have been supported. He's now 25.
Isn't that wonderful? And
It
he's
is
amazing.
wonderful.
And he's an amazing boy. He's
Yes,
loving and sweet and smart, and he's alive.
yes, wonderful. And I'll tell you, the doctors in Kenya told me, don't take him. Your life will be too difficult.
And it's been difficult,
It has been difficult,
but
but he survived and he gave me family and joy.
exactly.
Yeah.
So tell us what is, because I first heard about sickle cell anemia from you. I didn't know what it was. So tell us about this, and who does it affect primarily?
Okay, sickle cell disease is a genetic disease, an inherited disorder, which is found primarily in people of African descent, but it's also found genetically in people in the Middle East and some parts of South Asia. But it is the biggest killer. It creates a mass mortality in Africa of any genetic disease.
Wow.
We know we also have it in the African diaspora, in the United States, the Caribbean, etc. Now, what it does is it causes the red blood cells to become hard, sticky, and sickle-shaped instead of the usual soft and round shape of cells. And what this does is it makes harder for the red blood cells to carry oxygen through the small blood vessels. And so without oxygen, organs can be starved and all kinds of complications, many of them fatal, can occur. But among the main complications are severe pain, anemia, low blood counts, acute chest syndrome, which is pneumonia, infections, which, because the spleen stops functioning, are often fatal. So people with sickle cell have very little resistance to bacterial infections. And so they die very quickly from infections. And this is not known. You can't just give them Tylenol. They need IV antibiotics. So in this background, it's not difficult to understand why we have such a high mortality rate in countries with low incomes, in underserved communities.
Yeah, this complication from sickle cell, and I know your life has been incredible because you have been really having to take Shikuri to the hospital many times and so on. And it's, so you saved his life and you want many other children to be saved. And I'm gonna read something that I read on your website. In Homa Bay County, an estimated 4 to 5% of children are born with sickle cell disease. Many still die from preventable complications before they reach the age of 5. According to the WHO, the World Health Organization, they estimate every year, 250,000 children are born in Africa with the disease, and they are not diagnosed. 80% of them will die before they are 5 years old, as we said before. It's not that there is no treatment, but there is not consistent care. And it has been out of reach, this consistent care. And this is what you're trying to do. So what is the SHIKURI project? And why did you start it? And what does it focus on and its approaches?
Thank you, Maria. So the SHIKURI project, I'll tell you why I started it. When I retired, it occurred to me that I wanted to support in Kenya programs for children like my son who were not diagnosed and who he would have died had he not had the treatment. And I was horrified to read the WHO statistics that in sub-Saharan Africa and in parts of Kenya, we have this high death rate. And I tried to find organizations I could align with and support, and I couldn't find any.
Wow.
And so I decided to start my own. And I looked into my son's his ancestry, and found out that his birth mother's people came from Western Kenya, which has high sickle cell prevalence. Now, Kenya is a country that doesn't have sickle cell throughout. So a lot of people in Kenya don't know it because it's normally highlands and not in the malaria belt. But the parts of Kenya that are in the malaria belt with tropical rainforest conditions, they have sickle cell. It just so happens, too, that they are the most impoverished regions.
Of course.
And so they have a double whammy. This disease, poverty, and the lack of access. Sickle cell used to cost a lot to diagnose. But so let me go back a bit. I decided, okay, anything I can do will help, because if 70% are dying, if I can save one, hey. And that has kept me at it, because I know many of these people have no champions in the public sector who can help them. So I just keep at it. I named it after my son, because it's a condition that he has and I found out. And I met up, before I decided on the mandate of the program, I brought together physicians from New York in hematology, leading hematologists in Kenya, development professionals from UNICEF, and lead head of sickle cell in Homa Bay County, which is in Western Kenya, the ancestry of my son. And we deliberated on what could be the best type of program to deliver. And so we came up with this blueprint of what eventually became the SHIKURI Project, which is a program that we can anchor within local communities, partnering with the hospital, which can provide early diagnosis and continuous monitoring, or continual monitoring every 3 months, which is required. The lab works have to lab work has to be done. Yeah, blood work has to be done to assess the profile of the children, how they're doing. Medications provided, very critical, and referrals if they need hospitalization, etc., or surgery, which is sometimes required, but in a timely fashion. And of course, family training, because in these countries, they don't know it's a genetic disease. The mother is often blamed. Some are said that they're witches. Others feel that it is the mother who is the problem. And very often, the mothers and the children are ostracized, banished from the home. We have helped families who have had to move into parking lots because they've been thrown out from their homes. It is so a problem. So we're trying to teach them sensitively that it takes both partners to produce a child with sickle cell, because it's genetic. Both parents need to have the trait, for a child to be born with a full-blown disease.
Wow.
And so we're gently giving this education to the families when they come in, because if they have multiple deaths, we are treating families in our cohort of 30, some of whom have had 3, 4 children die and just buried there. So we have also been fortunate in creating the SHIKURI Project that there's been a game changer in diagnostic technology. Before, it used to cost a lot to diagnose, which is why there is no universal diagnosis in these under-resourced countries.
Yeah.
And because they die before 5, they leave without a trace. So there is no impetus to do anything.
Yes.
There's no data on them.
That's
but
terrible.
now, yes. So they suffer from that too. There's invisibility because they die. So the point of care testing kits, which can be done in the field locally, were developed, which allows diagnosis to occur at the cost of $10 a child. Before it was $400.
My God.
And it would take 3 months.
New technology.
When we started, we diagnosed children. We paid for diagnosis with the extra electrophoresis machinery, which is an old type of machinery, $400 a child. And it took 4 months to send it 400 miles away to get the test.
Wow.
Now, point of care testing, we bought 100 kits with our donations. We had $600 and we bought however many kits we did and diagnosed 50 people in the community, 30 of whom were children under 5. And having diagnosed them, we realized, well, now we have to take care of them. Let's put the project in action.
Fantastic.
And so, every
these
month.
are one of the 4 points that you have. Early diagnosis.
Yes.
Continuous treatment.
Yes.
Family support.
Yes.
And community-based follow-up.
Yes. Thank you for specifying it that clearly.
I just let you go with all those because they are fundamental, those points, very important.
Yes, absolutely. And those are the main prongs of the process. And so we provide the medication, which in many of these, in this county and generally is not provided. I mean, it costs, to treat a child costs $39 a month with everything. The medication, it's $40 a month, $40 a month. In our standard, that's not a lot for them. It's beyond reach.
Yeah.
So on a small scale, we've put the program into action. And I'm the lead head. I partner with the head of sickle cell in Homa Bay, who is the lead physician. And I send money for the medications, which are bought locally. We have a coordinator who is a clinician. And when the children, we bring in the children every 3 months for lab work and vitals, etc. And we track how they're doing. Some have malnutrition, and we try to give a little supplement for those. Some have no health insurance. We try to provide that. But even with health insurance, the medication isn't available for them.
And why not? Because if it does exist and they have health insurance, why the medication is not available?
This is a supply issue with the public authorities that I have no control over.
They don't care.
They're dealing with multiple issues. You have high death rates from malaria, all kinds of conditions, malnutrition, these areas, HIV, AIDS. So sickle cell is just one other issue, but the fact that it's ignored is reprehensible, but also the authorities are dealing with all these others. Now, what is even concerning is that children with sickle cell are more vulnerable to malaria, pneumonia, all these other killers.
Yeah.
And when they die, the cause of death is never attributed to sickle cell. It's attributed to pneumonia, or they get stroke also. infections. But this is to say, yeah, what was your question? I need to get back to it.
No, I just asked why don't they do
Why
it?
isn't the medication not there?
Yeah.
Yes. And until it gets there, we're trying to fill the gap.
Yes. Yes.
You know? And so every month when the children come for their 3 months, for their clinics every 3 months, we give the families the medication for 3 months. We also pay the community health workers. Kenya has a very good health infrastructure.
Ah.
So they have community health workers who are paid to go to, who, like, each worker may have 30 families that they're supposed to go and visit. You know, many of them are in out of reach areas in the mountains, etc. They go there and check on them and make sure that they're taking their medications. Yes. So we use the community health workforce to stay in touch with the families, and we find out what issues they have. We pay them a small stipend, about $10 a month, each community health worker. So we have 3, and that goes a long way. And they report to us when there are issues with the families. For instance, we have one family where the father has leprosy and the mother has special needs, cognitive special needs. And so the child is in some jeopardy. Wow. So they give them special help in dosing the medicines and so on. So these are the prongs of our program. Now, what is great, we started the program a year, we've been in existence since 2014, but we started delivering these clinics consistently in March 2025, and we exist only on donations. We have not been able to get donations from major grantors or benefactors, but people who believe in what we're doing donate, and we are able to keep these 30 children alive, and they've been doing fantastically well.
Wow. You saved 30 lives.
Yes, exactly. Right? Thank you.
And the fact that we need to talk about donation, the fact that you haven't been able to get large donation is incredible, because we are in what is supposed to be the richest country, right?
That's right.
So this is such a small thing, and that's one of the reasons why we're doing this interview.
And it's easy to show impact.
Exactly.
We're saving lives. This isn't something that you can't quantify.
And it's
major.
And you know where the money goes.
Exactly.
You give to your organization. We know where the money goes. The money goes to the needs, the people who need it, the children who need it, to save children.
I get no salary. The main doctor gets no salary. I mean, I raise money, give money, and the only person who gets paid is the clinician who coordinates their treatment monthly, and dispenses the medication to them and coordinates it all. And she stays in touch. And every week, we go through their data, see who is very sick, whose labs are low, who needs extensive care. We've had 2 children who've needed operations. And through the lab work, we knew that. Now, in Kenya, as in many countries, lab work isn't covered, even by health insurance, only when they're hospitalized. So that's why our program has to pay for it. It's about $10 for each child to get the lab work done. But we've kept them going, and they've been doing remarkably well. We've had a 70% reduction in hospitalizations. Many of them had painful crises, pain attacks. Those have been reduced by about 80%. So we have the data to show that. The school days, they're able to go to school. Their parents don't have to sell cattle to pay for them to be in hospital. They can focus on their livelihoods. You know, they're small peasants, fishermen, and so on. And it's been a game changer for them. and the families are jubilant
Yes.
and just so grateful that there is help. They're not forgotten. Save the Children, as far as we know, doesn't do anything for sickle cell, neither does UNICEF. All these organizations that you think are devoted to children. Maybe one day. We applied to the Gates Foundation, but I think we're too small. But we still keep doing it because our footprint is growing. And guess what? The county government is very happy about it. They say, look, we're giving clinics. So we're partnering with them to do it. And so they're happy to see that. But we're trying to show the government that, look, you invest in getting the medications for these children, you're going to save money on hospitalizations.
Exactly.
By giving them this medicine, it costs a third of what it takes to have them hospitalized on multiple occasions and still die.
Which is the usual thing. Prevention is better than taking care afterwards. And it should be a normal approach in medicine because this is what works. But the point is that the way that the big pharma, as they're called, work is that they don't really want you to be healthy, because if you're healthy, you don't need their medication and you don't need their help. So it's like
yeah, but at least, in this case, it's a big pharma who will help because they give us a medicine that will keep them healthy.
And that is wonderful. That is wonderful. But it's
yes,
a
preventive. And it's available.
It's a preventive medicine. That's what I'm talking about.
Yes, exactly.
Because all these medicine that they are advertised on TV, they are to treat something that could have been prevented. And then when you hear what the side effects are, sometimes are worse than what you are trying to take care of.
So because my son did so well on this medicine, I knew, hey, we can bring it to these needy community. And it's available there to be bought.
But it's too expensive.
And the government has limited supplies. So they might be able to give them for 3 months and then nothing.
And what's the name of this? Let's say.
Well, the medication is called hydroxyurea.
Hydroxyurea.
So it was a drug developed to treat leukemia. And in early 2000s, the Duke University discovered that it can treat sickle cell by increasing the fetal hemoglobin, which is what helps the red blood cells to perform optimally.
Wow. Yeah, because leukemia is a disease of the blood, so
that's right. Exactly.
Makes sense.
And it's been a game changer in the United States. So by comparison, in the United States, according to statistics, someone with sickle cell, on average, 80% live till at least 45, 50, some 70.
Wow.
It's still not so, but 80%. Sub-Saharan Africa, 70% estimated to die. So it's very shocking how little attention there is on this disease. But I'm here. As long as I have life and breath, I am doing what I can. I'll keep at it.
Thank you so much, Gail, for this very, very, very important conversation.
Thank you. And thanks for all watching. If anybody is moved or interested to donate, I'll tell you, for just $39 a month, a child can be treated and their survival assured, or improved chances of survival immensely improved. For $39 a month, they get medicine, clinical care, monitoring, community health support, and their chance of going to school and growing up. $39 a month. That's less than $500 a year.
To save the child.
Yes, exactly. So any amount helps. If you can give $20, that will be going towards their medicine.
Thank you again. I invite everybody to go on this website. It's very clearly explained what the project does. and it's easy to navigate, and it's not long. It's I mean, I read all that in about 20 minutes. So it's really a
Thank you, Maria.
fantastic website. So
Thank you.
Shikuri,
Thank you. We hope to go from strength to strength and increase the enrollment in the program.
yes.
Thank you, Maria.
Again. Thank you to my viewers. Go and see this website.
Thank you, viewers.
And donate to SHIKURI.org. Thank you, Gail.
And save a life.
Next Saturday, 12:30 p.m., channel 1993 on Spectrum, and on my YouTube channel, My Harlem Portraits. Bye-bye.
Bye, Bella.
Bye, Bella.